Hey, welcome to Plant Yourself. I'm your host, Howard Jacobson. Two quick announcements before we get to today's show. If you're interested in becoming a health coach, I'm offering another run due to popular demand for people who can't make 8 p.m. on Wednesday nights, Eastern Time. So we're doing another run of the program, which will meet, the practicums will meet at 10 a.m. on Wednesdays, Eastern Time, U.S., which means if you're in Europe or Africa, that might be good for you. Also, if you're in the U.S. and evenings aren't good and you have free time in the mornings, either 7 a.m. Pacific time or 10 to 11:30 Eastern, then you can participate. If you want to find out more about becoming a wicked effective health coach, you can go to wellstartcoach.com. Second thing is, if you're not aware of it, Josh Lajani and I have a book that is free on Amazon Kindle. It's called Sick to Fit. And if you just go to Amazon and search for Sick to Fit, you'll be able to download it for free and read it on any Kindle-enabled device, even a phone, smartphone, tablet, computer, whatever. All right, let's get to today's episode. This is the Plant Yourself podcast. I'm Howard Jacobson of plantyourself.com and wellstarthealth.com. This podcast is part of my mission to help you live an empowered and economical life. So you might be wondering, why economical? Sure, empowered, but economical is kind of a weird word to wish for a life. But it actually comes from the ancient Greek oikos, meaning home, household. And to be economical was simply to be a wise, frugal manager of your household resources. And if we look at our healthcare system as a giant household, it's not very economical. There's a tremendous amount of bloat. It's practically an extortion racket. And a lot of it has to do with the way prices are set in such an opaque manner that you can never actually tell what you're getting, how much it costs, what the value is, and whether there are other options that are available that would be better for you. And that's the topic of the first part of my conversation today with Emma Passé. Emma is a firecracker. She's the Chief Operating Officer at ePowered Benefits, which is one of the renegade benefits brokers who's challenging this bloated and broken healthcare system. She's partnered with David Contorno, who is so outspoken against the way things are currently done in the health brokerage system that it's joked that he needs to go to conferences with bodyguards, with protection. So I first met Emma a year ago at a healthcare conference, and she gave a keynote presentation. She brought down the house with her spirited, entertaining, and incisive look at how health plans negotiate prices with providers. And you wouldn't think that the topic of reference-based pricing would be all that interesting, especially to the non-wonks in the room like me. But Emma has a way of making it relevant and fun. And when you discover how you've been overpaying for healthcare all these years, you might become outraged as well, as I was. So when I found out that Emma was going to travel to Charlotte, North Carolina for a day of meetings, I hopped in my car, drove a couple hours with my portable podcasting studio, and met her for an interview. And I discovered, as you're about to, that Emma is not only brilliant and passionate about her work, but she's a great conversationalist as well. Over an hour and 37 minutes flew by. So this is quite a long podcast, one of the longest I've ever done. But there's really nothing that I want to cut. I just turned on the recorder and we chatted like old friends. And we talked about the healthcare system, the health insurance system, and how consumers and employers can start protecting themselves from this extortion racket. And we also talked about Emma's personal journey, which included losing 135 pounds, regaining her health, and also how she was perceived differently as a professional when she was thin, smarter, more competent, more powerful, more influential, and what that says about our society and body image issues for women. And we rounded out the conversation by chatting about her initiative to empower more leaders, especially women and millennials, to speak their truths and step into influential roles in their organizations and communities. So fasten your seatbelt for a wild ride into the world of health pricing. And before we get there, two quick announcements. One is WellStart Health is now offering pretty much every couple of weeks a new cohort, a 12-week intensive Reclaim Your Health big change sort of program. And if you'd like to find out more about that and join us, you can go to wellstarthealth.com/program. Second thing is, quick reminder that this podcast is free for everyone and it's supported by those who can afford it. So if you want to become a patron, just go to patreon.com, search for Plant Yourself, and you can help support this mission. All right, let's get on with the mission. Without further ado, Emma Passé, welcome to the Plant Yourself podcast.
Thank you. Thanks for having me.
It's a pleasure. We're here in beautiful... I don't know where we are. We're somewhere outside of Charlotte.
Mooresville, I think.
Mooresville. My GPS brought me here. I didn't have to think too hard.
Me too, except the GPS in my airplane.
Okay. So you had even less to worry about.
Yes. Yeah. I mean, statistically, yes.
Right. Right. Plus, yeah, I'm not worried about the other cars. I'm just worried about myself. So we're here. I've heard you speak at a bunch of conferences, and you are you call yourself a benefits broker?
Maybe consultant or advisor, but they kind of all fall into the same bucket. Yeah.
Okay, and maybe that's a really useful distinction to talk about. Like, when I think about benefits, I think the word broker comes to mind, but there's different flavors of that. Maybe just start out by just describing like what you do.
Okay, so I think the main difference between being a consultant / advisor and a broker is just the being a little bit more robust in your advice out to clients. So when I think of a broker, I really think of someone who's fairly transactional in nature. And when I think of a consultant, I think of someone that kind of goes outside of that transaction and starts consulting on things that are a little outside of that circle. So I consider myself a consultant because I frequently find myself outside of the circle, whether I want to be or not. And what I do is I work for ePowered Benefits. Everyone's, I think, pretty familiar with the firm. We are an employee benefits agency, which sounds pretty run-of-the-mill, but what's unique about our agency is that we only work with non-network health plans, and we build them for our clients. And all of our clients are in a very open model that is completely transparent. And our main goal is to reduce costs to employers and employees and to improve the quality of care and the accessibility of care for employees.
Okay. So with that as a background, let's pull back to 35,000 feet and talk about healthcare. I saw on LinkedIn you were recently with Josh Luke.
Yes.
Whom I've had on the podcast, and we talked about the 6 words that kill the healthcare system. From your perspective, what does the American healthcare system look like, and where is there room for improvement?
Oh my gosh. Well, I have an interesting perspective because a lot of people don't know, but I was born and raised in the southwest of England, and I am a permanent resident here in the U.S. I have been for many years, but I grew up in the national health system. So when I first came here to America and I was a teenager, the health system was completely foreign to me in lots of ways. I remember one of my first questions when I signed up for my first health plan as an employee somewhere was, hold on, I have to pay premiums and deductibles and copays? And I remember questioning from the very beginning, when do my benefits start? What am I really paying for? And
that reminds me of like when I was left college, it didn't occur to me that I would ever have to pay for like toilet paper.
Well, because you take these things for granted, right? I grew up in a system that it's fairly widely criticized over here, I think mostly through lack of understanding. But I grew up in a system where if you needed to see a doctor, you just called, made an appointment, or walked in and went to see a doctor. And there was not a whole lot of worry behind the scenes about what was going to come next, other than you were going to get care and hopefully get better. Here in the healthcare system, it's such a process. I was at a client meeting earlier this morning, and I was trying to go over at a very member-focused level on how to engage in the healthcare system successfully. And I find myself explaining it in this 15-part series and expecting the average consumer to understand, and they simply don't. In terms of improvement, there's so many ways we can improve it. It's the way that we bill for care, the way that we as a collective, meaning hospitals, facilities, providers, the way they're coming up with the cost of care that they expect an average member to be able to A, afford, and B, actually pay. And a lot of that is pushed back onto the employer, as if we expect them to be able to afford and pay those bills, and they simply can't. So what our agency really focuses on is not necessarily the functions within the system, but just simply where the bill starts and how big the bill is in the beginning, and just trying to drive that down to a more reasonable level. And that is actually where reference-based pricing kind of came into play.
All right, so let's talk about reference-based pricing, and I have you here because I've heard you explain this like to a level that a teenager could understand.
Yeah.
So before we get to reference-based pricing, maybe we talk about what is commonly done, which is kind of the opposite. So how and the way you describe it, it's clearly insane. But we don't think about it until you. So could you do that show?
Yes. So the way that it works currently, and I'll start with the way that it works because reference-based pricing essentially works in reverse. And it's fairly straightforward when you break it down that way. But the way that it works right now in a traditional PPO health plan model is
PPO. I'm going to keep
preferred provider organization.
Right.
So that's if you're with one of the big health insurance carriers and you have a network of providers that have contracted with that carrier to say, we'll provide care to your members and we'll give you a discount. And no one can see, but I'm using air quotes for my discount there because the problem with that is that the starting price gets set wherever it wants to be set or wherever someone wants to start it. And then the discount comes off of that. Well, the CEO of our company says something that really resonates with me, which is I'll sell you my car at a 99% discount as long as I get to set the starting price, right? And that's kind of how it works in healthcare. The discounts become completely irrelevant if somebody else is setting the starting price way above what it should be. And that's how it works right now.
Okay. So I'm an employee of a company. I have my health plan. The company has negotiated with a benefit broker or advisor or consultant for the plan for this year. Let's say they're going to go with Blue Cross. And Blue Cross has then negotiated, the local Blue Cross has negotiated with, let's say in my area, Duke Hospital System or UNC Hospital System and all their network providers, and they've gotten some good deals for me. And I don't know in advance what I might need, but I'm just, my employer is trusting that whatever I need is going to be provided at some sort of good deal. And the problem is that the deal is 40% off.
Right.
Of 40% off of what?
Exactly. That's the question that we're all asking. 40% off of what? That charge starts somewhere that we can't really identify. I mean, we can sort of pick apart at a few maybes, but who sets the starting price? What justifies the starting price? And it varies from facility to facility, provider to provider, state from state, city from city. So your question is the most valid question I've heard anybody ask so far, which is a discount off of what? Okay. And it's that big question mark that we're trying to fight against without really knowing how that's set.
Okay. So this would be like, let's say my employer has this benefit that I get 40% off of everything at Panera.
That would be great, but right? Yes.
But Panera doesn't have prices on the menu.
Right.
And every single Panera has different pricing. So if I get 40% off, they see that I've gotten 40% off, and then they go back in the back room and they calculate, okay, well, the soup, we want to make $10 on the soup and the hollowed out bread, so we're going to charge $16 and then give you 40% off of that.
Well, the bottom line is every business needs to make a profit, right? So even if you're shopping somewhere that has a discount or a bargain or a coupon, no matter how much money you get off of the starting price, chances are that business is still making a profit, and otherwise they wouldn't be in business anymore. And so the discounting methodology doesn't really make a whole lot of sense, because if you're a provider who needs to make $150 for every office visit, and you've agreed to give a big carrier a 40% discount, well, chances are that you're going to increase your billed amount for your office visit so that even with the discount, you're still going to make the money that you need to cover cost and give you a little bit of profit. So the discount, again with the air quotes, is sort of irrelevant. But a lot of people buy insurance based on the best discounts.
Right. Now, and for me as the end user of this health, whatever the intervention is, I'm going to pay a copay maybe, or maybe not. So I don't really care what the price is. I may never even see it. Like sometimes I'll go in for something, like I had some blood drawn, and I get this like 4-page statement like 3 days later that I look at, and my eyeballs start bleeding because I don't understand almost any of it.
Right. Like
there are some dollar signs in there. I go, oh yeah, I recognize dollar signs, but I don't understand the codes or anything else. and there's like 7 columns of dollar signs, like who what they pay, what my insurance pay, what I have to pay, and basically if it doesn't come with a return envelope, I completely ignore it because I know they don't need any more money from me.
Mm-hmm.
So there seems like there's an incentive for whoever is giving the discount to raise the price as high as possible, since there's no accountability for it.
Well, I think it seems that way, but that's sort of where consumerism gets lost, because the member does see that. So if you're the end user and you have a $25 copay, but perhaps your service was a few $100s, someone is paying the few $100s on your behalf. And if you're a self-funded employer, it's the employer. And even if you're fully insured, the carrier is paying it, but at the end of the day, they make that up in premium. So even if you're a fully insured group, you're going to see those dollars translate into your increase the next year, right? And that does extend to the employees too, because the employees are the ones that get the deductibles raised at their renewals. They're the ones that get their contributions raised when their plan renews too. So while you don't see it immediately as a consumer, as a health plan member, maybe you're thinking, well, I don't really care how much it costs because I just have this $25 copay. But come renewal time, when your contributions go up 15, 16, 17% because the company has to absorb the amount of those excess claims, you're going to feel it that way instead. So it's sort of cost shifting in a way.
But there's two things going on that separate me. One is like, pain of purchase, right? Like in the example I'm thinking about is if I ate at a fancy restaurant and every time I took a bite of my food, they just gave me a bill for like 50 cents, right? Like each bite would be far less pleasurable
right.
than if I just could eat and then just get the bill at the end.
Mm-hmm.
So that if I'm, if the pain comes the following year with renewals,
mm-hmm.
then I don't really feel it in that moment, and I'm not inspired to make a change. And the other is sort of the tragedy of the commons, where like I want as much as possible for myself. And it's like other people who are causing the problem, not me.
Right. Yeah. And I think that's where we're missing some of the consumerism on the employee level. Not because they don't want to engage, but because it's not really clear to them. And I think it can be really damaging to employees who have bigger costs, because once your example was great. Most people encounter the healthcare system at the copay level out of their pocket. Contributions aside. But if you're somebody who has a high deductible health plan, for example, where you have to meet your deductible before any benefits kick in at all, then the cost of a service might be more important to you if you have to hit a $5,000 deductible first. And I won't get on my soapbox about HDHP's high deductible health plans, but the intent was always to encourage consumerism, right? If we make employees put a little bit of skin in the game, then they'll be better consumers. And unfortunately, that hasn't happened. It's led to a lot of mismanagement of chronic conditions because people simply can't afford now to engage in the healthcare system, because instead of a copay, they have a deductible.
So people are being disincented from getting the cheap, relevant, appropriate care early until the point where now like the primary care visit was $100 and the test was another $200, but that was going to come out of my pocket. Mm-hmm. But now we've reached the stage where I need renal care for $12,000, so now someone else is picking up the tab?
Yeah, pretty much.
Wow. See, I just, I have a high deductible plan that's like, $10,000 for the family. So I just assume, God willing, we will not need it.
Mm-hmm.
So I'll go to the Quest labs and say, what's your cash price?
Yeah, I mean, I think a lot of people, if they really took the time to ask those questions and sort of dig in a little bit, they'll find that the way that the insurance billing really works and how things are paid for is not necessarily to their advantage. And not only that, but if we're going to get a little bit liberal in thought process, if you work for an employer that truly takes care of you and you care about the people that you work with or the people that you report to, if you have that kind of relationship, then I think a little bit you should care about what your employer is paying for on your behalf, right? It's a lot of brokers use the total compensation statement as a reference to like, here's how much your employer cares about you. They're paying X amount for your health insurance. And I think sometimes that gets lost at the member level, but someone is paying, whether it's you directly or not. But if the difference is if you're paying, you care a little bit more about it, right? Than if somebody else is paying. If you're taking me out to dinner after this and you're paying, I might order a steak that's a little bit more expensive because I'm like, Howard's paying. But if I'm paying, I might order, some sushi or something. So
yeah, we're definitely splitting the bill.
we're going
By
Dutch.
the way. I can't be responsible for your steak.
All right.
So, no, I'm totally off track. Where was I?
Steak.
Right. No, I'm back off track. Well, so you said you didn't want to get on a soapbox about high deductible health plans, but was that the soapbox?
It was part of it. Yes.
I want to make sure we get the whole soapbox.
Well, the soapbox is that I'm kind of a data geek, and I've worked in this industry for a long time, and analytics and data has really fascinated me, and I think I have a fairly analytical personality, and I consider myself a strategic thinker. And one thing that I started noticing about high deductible health plans a few years ago was that they drive employer costs down significantly in the first couple of years. But if you take a look at the trend of a high deductible health plan, its utilization over a 3 to 5 year period, you'll see a couple of things happen. The cost go down because it's being shifted. The responsibility of the cost is being shifted onto the employee. But if you are providing that plan to a group of employees who are blue collar, low wage, don't make enough money to cover a $5,000 deductible, and have perhaps some comorbidities or some kind of chronic condition, chances are that employee won't be able to afford to maintain their condition. And so what you end up seeing on a 3 to 5 year trend is the amount of chronic conditions in the population gets higher, and they become more unmanaged over time, which when you think about the effect of that over a longer period, it's going to result in bigger, more catastrophic claims happening somewhere down the road because something wasn't managed appropriately. And that's an affordability issue.
So, I mean, I'm trying to translate this into terms I understand. It'd be like if I decide I'm going to save money over the next few years by not maintaining my cars, right? So I'm not going to go for oil changes. I'm not going to do the 50,000 mile thing. And, every year I might save $1,000, $2,000, but like by year 3, or 4 or 5, depending on the make and model, I may have to end up getting a whole new vehicle because I didn't maintain it. Like, is that not? It seems obvious to me. Is that not obvious in healthcare?
Great analogy. I'm totally going to steal it. I'll give you credit for it, but it's not. And what's crazier to me, as someone who, we kind of touched on it in the beginning, as someone who went through a health journey, it's crazy to me that we don't take care of ourselves in the same way that we would a car, right? Because we do maintain our cars, we maintain our homes, we maintain our roofs. But when it comes to us, we push it off as if that's the lowest on our priority list. But you're right, because if you don't maintain your health, if you're not getting the medication that you need or the test strips that you need or the checkups that you need, ultimately that's going to compound over time, and you're going to run into a bigger illness or a bigger event where now you have to engage your healthcare and you're forced to pay what you would have paid over, a longer period of time, and chances are the bill will be a lot higher.
Right. Although in some way it almost argues for the high deductible health plan because that's how we do car insurance, right? I don't submit a claim for the windshield wiper that needs to be replaced. What's the difference? I mean, maybe I don't know if you thought about this, like psychologically, around a car versus a body.
Well, I mean, first, the longevity, right? I mean, hopefully we're all going to live into our 90s, maybe to 100. I don't think cars last that long, although I've never, investigated that. But Uncle Freddie really took good care of his MG. Yeah,
he might still be out there.
I mean, I think a lot more people, once they kind of figure out that it is more cost efficient for them to just pay out of pocket sometimes, especially if you can get a cash price for something that's maintenance in nature, a lot more people are setting aside their health insurance plan. And what we're trying to do at ePowered is bring that ability to negotiate on a cash price basis into an insurance plan so that it can be leveraged and used, and you can still have protection for those bigger things down the road or those emergencies.
So we started off on this to explain reference-based pricing in comparison to what exists now.
Yes.
So what is reference-based pricing?
It is simply the way that we pay for healthcare. So remember I said right now in a PPO environment, there is a starting price that's way up to the ceiling, and then we take a discount off of the starting price. What we do in reference-based pricing is we use a reported reference price, and in most cases, most commonly, we use Medicare prices. So this is data that's reported by providers to CMS every single year, and it's their CMS, the Center for Medicare. So that's how Medicare sets their rates. They rely on providers to report their cost plus a little bit of margin to CMS. And so they know the price by procedure for most procedures.
And they tell the truth?
They have to, yes. Integrity still exists, I think. But they report the cost to CMS, and then we take those costs. We take the provider-reported costs that we know have been reported by that same community, and then we mark them up. We give them a reasonable profit on top, and that might be 150, even 160% of whatever Medicare would pay for that. So we do it in reverse, where the PPO starts with a ceiling price and takes a discount. We start at the reported cost, and then we provide profit on top. That's essentially what reference-based pricing is.
Mm-hmm. And I guess the main difference is that with the Medicare cost, you know what it is in advance.
Right. Yeah, that's the key, is that we're using a price that's already been verified and validated, and then we're deciding, based on a lot of data analysis generally, we're deciding what is a good, tolerable profit margin that we can include for providers so that they'll be accepting of the plan.
So this reminds me of a little bit is when I was a kid, my dad was on the New Jersey Public Utilities Commission, which had to set rates for the utilities, which were in those days all monopolies, and they were guaranteed profit by the government, but not unlimited profit. Right? Is that like?
I mean, yeah, kind of. There's similarities for sure. I think that essentially when you break it down, and I can give my backpack analogy, although I feel like your listeners are probably a little bit sophisticated, so they...
Well, they are, but I'm not. So
I could give
tell
you
the backpack.
So the backpack analogy was I was asked, it's been a while now, maybe a year ago, by a Portland company. I'm from Portland. I live in Portland. They asked me if I could explain reference-based pricing so that a 10-year-old could understand. And I had the questions in advance, and I thought about it, and I kept coming up with these responses that I knew no child would ever understand. Well, at the time I had a 12-year-old daughter. I still have her. She's just 13 now. And I called her down from her bedroom, which is just such a feat to get her in any common area at all. And I said to her name's Molly, I said, Molly, I want to explain something to you, and all you have to do is tell me if you understand yes or no. And I usually do a good impression of her. I'm not sure if it'll come over well on podcast, but she was agreeable. She said, okay. And so I said, okay. And I started down the path. I said, okay, let's say I get a sinus infection, and I go to the doctor. And after I've had that interaction, I get a bill. The bill goes to the TPA, and I'm going on, and my daughter's just like, I'm out. I don't know what you're talking about. And so it took me a couple of tries, and I looked at my refrigerator, and there was a back to school list there, and I said, okay, what item do we need to get? This was over the summer. And she said, I don't know, a backpack. I said, okay, backpack. So let's say we go shopping for a backpack, and we go to Walmart, and maybe there's a whole wall, shelves full of backpacks that are all about the same size. They all hold the same amount of stuff. Maybe they have different patterns, or the colors vary, but they're all about the same, and they're all about $10. And then maybe later we go walking down to the park, and maybe your friend shows up and she's selling a backpack, and the backpack is pretty cool. Maybe you like the colors and the pattern a little better than what we saw at Walmart earlier, but it's the same size, it holds the same amount of stuff, it's a backpack. I mean, your friend wants to sell it to you for $50. And I'm kind of keeping my daughter's attention at this point, and so I go on to tell her, what we do in this situation is we negotiate with your friend, and we tell your friend, we know that there is a shelf full of backpacks that are being sold and consumed all the time for $10. And you're trying to sell yours for $50. So since we want to buy yours, or maybe in some cases in healthcare, we have to buy yours, we're going to start at our reference price of $10 where we know we can buy it, and then we're going to give you a little bit of profit for conducting the transaction with us. So how about we settle around $15? And I said to my daughter, does that make sense? And she very begrudgingly said, yeah, I guess, but that's essentially what it is, except we're talking about consuming healthcare, not off a shelf all the time, but in a doctor's office. And we're talking about using those Medicare allowable amounts to start our negotiation price with a provider.
Gotcha. So when I think about the Walmart analogy, of course, my mind goes to sweatshops and stuff like that, which brings me to this whole concept of like healthcare burnout and like the market says, well, since doctors and nurses and other healthcare practitioners have such horrible jobs, we need to incent them to do them by paying them huge, the yacht bonus. But that's not really, like, we know doctors, that's not what they want.
No, I mean, the nice thing about e-powered benefits is that we really work a lot more on the clinical side of the fence, almost just as much as the insurance side. And that's sort of a new awakening to me, because I've always worked on the insurance side. But we speak with doctors, we talk about direct primary care, and what we find consistently, without a doubt, is that doctors just want to practice medicine. That's what they went to school for. They enjoy working with patients. They enjoy making people better. I've interviewed Dr. Rick Rosenfield from Portland, and he sort of said the same thing, is that they just want to provide good care and make people better. And what's happening now is that they're spending more of their time dealing with submitting insurance claims, providing those procedure codes and medical records and case notes, and then arguing back and forth when they get their reimbursement, and then chasing down members for their portion of the patient responsibility that most of the time people can't afford. And so doctors aren't getting to do what they want to do anymore.
Well, it seems I have some doctor friends, and it seems like the electronic health record, which was supposed to rationalize care, and it has turned into like this stealth pipeline for doctors to turn into billing administrators.
Yeah, and I think more and more of their costs are going towards administrative headaches that they have to deal with now. And so they're spending more money on the staff that they need in administration to chase down the payments. And so the time that they spend with their patients is less than ever. And the time that patients have to wait to get an appointment is more than ever. And I think direct primary care has a pretty big spot here in what the resolution really is, which is allowing providers to provide care to patients without the headache of insurance, and it's working really well.
So what is direct primary care?
Direct primary care is a collection of primary care doctors who provide care to members based on usually a flat monthly fee or subscription fee, and they don't bill insurance. So regular doctors are generally fee for service, and direct primary care doctors, they generally create a practice where the accessibility is usually same day, next day. They tend to spend a little bit more time with their patients, and the money that they bring in is from that monthly cost rather than a back and forth with insurance.
So is that more like getting paid for results as opposed to procedures?
Not necessarily, no, because the rate for a DPC subscription is pretty static month over month, and they don't get paid anything additional. If you're a true DPC, you're not going to get paid anything additionally. So
right, but still, that feels like being paid for results in that if you keep people well, you get paid for working less.
Oh, well, in that sense, yes, absolutely, and that's a really good point, because if you do keep people well, then they come in less, right? So you're picking up a subscription cost for not having to see as many patients. You're right about that, yes.
Yeah. So it's like the gym that hopes that nobody shows up, except in a good way.
That's a fair assessment too, I think.
I mean, just in terms of like I've looked at different parts of the medical system where, like for example, oncologists can make money prescribing chemo drugs.
Yes.
And they prescribe through the roof. And like we see all these different examples where, like the dollars for docs from ProPublica, that you can't help but being influenced by your incentives.
Yeah. Well, and if you strip away those incentives and allow doctors to just practice medicine, you tend to have happier doctors, which generally translates to happier patients. There's a doctor, I completely forget his last name now. His first name is Jan, Dr. Jan. And I met him in Los Angeles just about a week or two ago. And he is a DPC doctor, and he was very open in his revelation that he makes more money now as a DPC doctor than he ever did in the traditional system. And really, exactly to your point, because all of his patients are paying a monthly subscription fee no matter what, whether they come in or whether they don't. And if he keeps them well and he does a good job, they don't. And so he gets to make more money, and that there is his incentive, and at the same time he gets to do what he actually wants to do.
And what's exciting to me about that, given my company WellStart, is that we want people to learn how to be well. And right now, the big issue in lifestyle medicine is how do we get paid for things that, like talking to someone for 15 minutes about broccoli and rice, where there's no code for that.
Right.
We have to play with the system. We have to figure out how to pretend that that's a real code somehow, or do educational systems, as opposed to, boy, if they just come in and I see them for 10 minutes and re-up their Byetta prescription, or now I put them on some new thing, like that's responsible.
Right.
I was talking with someone, a cardiologist in Florida, who was on the podcast, who's saying like she gets a lot of pressure from her administration because she's not doing enough stents and bypasses because she's making people well.
Right.
And it sounds like the DPC model, doctors get incented, or at least not disincented, from practicing good medicine, preventive care, and whole patient care.
Yeah, and I think we tend to see that employees or DPC patients tend to be happier as well. I have engaged with DPC. I've talked about this before, but I chose to go down the DPC path myself, and I worked with Dr. Alex Lickerman in Chicago. And I really did it because at the time I had a medical need, but also because I'm out here in the community talking about direct primary care, and I like to put my money where my mouth is. And I remember our first appointment, which was telephonically because he's in Chicago and I'm in Portland. And he asked me to schedule like an hour and 15 minutes for our intake appointment over the phone. And I remember thinking, an hour and 15 minutes, like, that seems like a long time. And lo and behold, I think we were actually on the phone for more than an hour and a half. And a lot of the things that he asked me, health questions aside right off the front, was really about my lifestyle and my feelings and what I do for work and what stresses me out and how do I sleep. And I've been in and out of the healthcare system fairly frequently as an adult. And that was the first time that I'd had an interaction with a doctor where I felt like he was legitimately trying to get to know me as more than just a patient, but as a person. And over the next few weeks that he and I conversed for actual medical issues, every time I spoke with him, I felt like I didn't have to re-explain who I was every time I needed to get something from him as a provider, because he had already taken the time to get to know me. And I think a lot of people have that exact same experience with direct primary care, that they spend more time with their provider actually building a relationship that helps the provider treat them at some point down the road.
Yeah, it's almost like if the current system is like an auto shop. I keep coming back to that metaphor. That all the mechanic is being paid for is like turning screws and nuts and swapping things out, as opposed to actually then getting in the vehicle and seeing, does it actually drive down the road? Does it pull left or right? Does it sputter and stop?
Right.
I just did a podcast this week with Dr. Wayne Jonas, who was head of the NIH Office of Alternative Medicine, and he wrote a book called How Healing Works. And he talked about like basically 70% of healing comes from people's meaning and context around what they care about.
Right.
And we think of that as like placebo,
right?
But really, what the technical stuff of what the medical profession does is maybe 20-25% of all of healing. So by Alex Lickerman asking you all these questions, it's probably also connecting you with like what are your reasons to be healthy?
Right. And I think you're right about that. I think if it is a placebo, it's a very powerful one.
Right. Yeah, and like the word placebo is like denigrating a little bit, like,
right.
Crazy person, it's all in your head, as opposed to like, I have this power.
Right.
Like somebody tells Superman that he can't fly. And it's like, well, before I could fly.
Right.
Like, it's all in your head.
Yeah, fair.
There's like this Jewish joke about Uncle Benjamin who goes crazy and thinks he's a chicken. And they ask, the family, how come you don't take him to a doctor to get his head made straight? It's so embarrassing. They go, yeah, it is embarrassing, but we could use the eggs.
I have a Jewish friend that would love that.
Okay. Steal it too. It's not mine. So the next thing I wanted to get an understanding of, and this is I was on LinkedIn this morning reading your most recent article, which is I think from about 2 months ago. Basically about negotiation versus litigation, and like a lot of that is inside baseball for benefits people. So I didn't even try to understand it. But you talk about balance billing,
yes,
and balance billing seems to be the thing that people throw out as a reason why reference-based pricing is a terrible idea.
Yeah, they do it with such frequency. It's becoming less and less surprising.
So what is balance billing?
Well,
why is it used as a cudgel against reference-based pricing, and why is that wrong?
Well, let's go back to the PPO versus RBP thing, right? So we got a big starting price in the PPO, and then we have a discount off of that starting price, and then the rest gets paid between an employer health plan and a member. Well, that amount, that 40% that the provider has agreed to write off, that gets written off. There's a contract in place that the provider has signed and said, we won't charge this to anybody. We won't assess it to anybody. In a reference-based pricing environment, we don't have networks, and so we don't use contracts with providers. We allow people to go to any provider they want without a contract, without a discount arrangement. So if a provider sends in a bill for $1,000 and perhaps the health plan has assessed via its reimbursement level, 150, 160% of Medicare, that perhaps they're only going to pay, $2,000. Wait, what was the starting price of the bill? 1,000.
1,000.
Sorry. Sometimes I do 1,000 and sometimes I do 5,000. If the bill's $1,000 and maybe the plan's going to pay $250 of it, and maybe $50 of that is member responsibility and $200 gets paid by the plan. Well, there's an amount in between, right, that doesn't get paid, and there's no contract in place that says the provider is required to write that off like there would be in a PPO environment. So that amount between what's billed and what's actually paid can be billed back to the member. The reason I remain slightly surprised that people use this as a reason to not do it is because the rate of balance bills is actually fairly low in a well-managed RBP plan. And I've argued this with a couple of other RBP people before. And my opinion is if you're setting your reimbursement at an amount that benefits providers, you're not trying to rip them off, you're not trying to pay them less than cost, you're actually paying them cost plus profit in a tolerable, comfortable amount, chances are your provider is going to accept that 98% of the time. Now, when we get into the bigger bills and into the bigger hospital systems, they tend to dig their feet in a little bit. And that's where negotiation comes in, where the member receives this balance bill, and then our negotiation team, something like a 6 Degrees Health or an AMPS, will step in, and some TPAs do it too, and start...
TPA?
Third-party administrator, sorry. They'll step in and they'll work with the provider to either get the balance written off or negotiate it down to a lower amount that the health plan would be willing to pay. I think...
So I'm not quite getting it. I don't know if there's a backpack example for balance billing, which is kind of what I'm looking for. But so let's say the friend has this amazing backpack, and it's got like RFID pockets and all this extra stuff your daughter needs, but it's so it's $500, and it's going to be billed to you, right?
Okay.
You're the one who takes care of the backpack, and then you discover that no, Molly, I was going to pay at most $50. Right. So now you're on the hook for the other $450.
Or Molly would be. Yeah, Molly, she's the consumer in this example, right? So Molly would be if the provider chooses to go that route. Now
would Molly know that it's that much?
To how much the provider billed?
Yeah.
Not until they billed it. No. Okay. So no one really knows what the price of healthcare is until the bill gets sent to an entity.
Uh-huh. And is that because someone comes in for care and you don't know what they need until, we did this x-ray and it looks worse, and this is a serious thing, so we better get you in? Like, where's like, I'm trying to figure out what's that balance, like, how predictable is it, and where does it come from, and why does it need to exist at all if we know the prices up front?
Well, I think predictability doesn't occur in the traditional model at all, because the price can be whatever the price is. But remember, in reference-based pricing, we are paying based on a reference reported price, but that's not what the providers bill on. The providers still bill whatever amount they would normally have billed. And there's no consistency or rhyme or reason to that, generally speaking. So a balance bill is essentially the difference between what a provider billed and what was paid by a health plan and a member. And generally there's a delta, because even in a traditional model, if a provider bills $1,000, never is a health plan and a member, between the two of them, going to pay the full billed price, usually. Maybe dental insurance might be an exception to that. Some dental plans pay billed charges.
So it's still a game.
Absolutely.
We're going to throw out a number, and we're going to see how much we can get of that number.
Yep. That's you're breaking it down in really simple terms, and it works. It's essentially, we're going to throw this out, and hopefully someone's going to pay us as much of that number as possible.
Well, that sounds like regular life. Like I go to a car dealership, and they're going to throw out a price, and if I pay it, someone's going to need resuscitation because they've never seen it before. I'm supposed to negotiate.
Right, but in healthcare we don't. We should. We are in some of our plans now, but we should be negotiating, especially because we know, like, when you go buy a car, I don't think I've ever met anyone who has paid the sticker price on a car before, right? The starting price is generally inflated so that negotiations can occur in those types of transactions. And that's essentially what we do in reference-based pricing plans when we're talking about balance bills. Is the provider wants the difference. They want that money that they billed for, as much of it as possible. And if the health plan has already paid their share, then the only person left to bill for that is the member. And the difference then between getting a balance bill in a PPO plan versus our RBP plans, because keep in mind, balance bills happen in those plans too. If you go out of network, if you're in a Blue Cross plan, and you have a surgery and your anesthesiologist is out of network, as they so frequently are, you're going to get a balance bill from that anesthesiologist for the same reason. They billed a certain amount, your plan paid a low out-of-network reimbursement, and now they can bill the member because they don't have a contract. Mm-hmm. Well, in that environment, the member is responsible, period. There's no advocacy, there's no one that's going to negotiate unless they do themselves. And in these plans, balance bills, when they do happen, which is relatively infrequently, a team of people at either the repricer level or the third-party administrator level will step in and work with the provider so the member doesn't have to.
Mm-hmm. And we were just at that World Healthcare Congress in Washington, D.C., and I'm blanking on the name of the speaker the final morning. who was giving all these examples of hospitals taking advantage of poor people. Right.
Dr. Marty McCary?
Yeah.
Yeah, he's wonderful, isn't he?
Yeah, what amazing presentation it was. But just, putting up people's faces and then talking about how, like, the hospitals, they've got to make their money, and the weak link is to go after these individuals. So in it with a regular PPO out-of-network plan, there's no one on their side.
Right. And I think that's what people miss sometimes, because these plans, when we implement reference-based pricing plans, there is some disruption and there's some unfamiliarity to the member about what they have to do. Because, quite frankly, in these kind of plans, there is a role for them. There is a portion of the work that they have to do. Now, it's fairly administrative and straightforward, which is just if you get a bill that doesn't match your explanation of benefits, then you need to do something with it, and usually it's just send it somewhere. But there's something that they have to do, and if they don't do it, it can become really overwhelming at the member level to know what to do. But in a PPO environment, there's nothing you can do. At least over here, yes, there's a couple steps that a member has to take, but it gets taken out of their hands and off of their shoulders and off of their hearts and their minds. In the other side of the fence, when they get an out-of-network balance bill, it's too bad. You're not going to get a carrier, a UHC, a Cigna, a Blue Cross, an Aetna. No one is going to advocate for a member who went out-of-network and received a balance bill, period. That's member responsibility, and they have to figure out how to pay it.
And it sounds like, do you sort of help employers educate their employees? Because I just had an experience with my 23-year-old daughter, who discovered that you have to register your car every year, when she got a ticket for, like, having a old registration sticker, and she comes home and she's like, "You failed," to point out, like, "You didn't teach me how to adult this thing." And, like,
way to go, Dad.
And I was thinking about it, like, you know what? She's absolutely right. Like, this is, like, it didn't occur to me that someone wouldn't know that, but that employees are not benefits professionals. They like we get this stuff in the mail all the time. Like, it seems like educating people to navigate the healthcare system, which in a sense I think is what this episode of the podcast might partly be for, to help people understand how to make things better for themselves. Yeah,
and I love that idea, and I wish more people were engaged in it, because quite frankly, it's frustrating. And if they felt the frustration, or if they were angered about it or emotional about it, I think that they would be more willing to participate in some of the fixes and some of the solutions of it. And sometimes that's what it takes. Sometimes it takes standing in front of a group of people and educating them on everything that's wrong to get them a little bit riled up and motivate them to say, I'm not going to do this anymore. I'm not going to participate in this anymore. I'm going to do a slightly harder thing or a slightly more complicated thing and contribute to the solution. And oftentimes, as long as the education has been mandatory for the employee, as long as an employer says, you must come to these educational meetings, and we can get in front of them and tell them, here is your 3-step process, we don't generally see a whole lot of pushback or problems. Occasionally, we have providers and facilities that are just not willing to play and not willing to negotiate. But if you look up the rate of how many of these actually go to litigation, it's pretty low. I mean, we get through the negotiation process relatively unscathed most of the time. And in our models, now, a good differentiator is that technically in the balance bill, the member is responsible for the balance bill. Because again, there's no contract between the provider and the insurance payer, whoever that is, the healthcare payer. So technically, the member is responsible for that bill, but none of our plans allow for the member to actually take on that responsibility. We talk to our employers, we make sure our employers know that these things are going to happen, and if we have to negotiate and we have to pay a provider a little bit more than we would normally, that has to come from the health plan, and we still need to keep the member protected.
So it sounds like that this this is such a sort of esoteric part of the healthcare system that people, like we think about, like, like curing cancer and coming up. Like, we don't think about the deep implications of just how payment happens as determining the system. But it seems like this sort of plan also allows employers and their employees to be on the same page.
Yes.
As opposed to an adversarial relationship, which we see in so many organizations. Like employees kind of hate the company kind of hates the employees, and they're both like necessary evils.
Well, let me give you an example, right? So I'm in North Carolina right now. I'm from Portland, Oregon. That's where I live. So I flew out here to do a meeting with one of our clients this morning. So we were out in Salisbury, I think that's how you say it, Salisbury, North Carolina. And we met with a bunch of members, and this is a fairly large group, but there was a little pocket of members that had a balance bill. And as a percentage of their population, definitely less than 3%, I think, of all the population, and less than 1% of all claims as an organization. But I went out there to talk to them, and we started the conversation with them being frustrated at the process because they didn't know what they were supposed to do. What is my role? What am I supposed to do here? I just have bills and I don't know what to do with them. And as we went through the conversation, number one, education cleared it up almost immediately. Here's what you have to do. Take yourself out of the middle. But one of the things that came up in the conversation was the reminder that this plan has had reference-based pricing. This is their third year now. And for the last 2 years, their contributions and their deductibles have been cut in half at every renewal. And I can't even tell you a consultant or a health plan or an insurance carrier agent plan that has been able to cut their costs to their employees and the employer in half ever. And so these employees were reminded today that if they wanted to, if it was really that painful, they could go back to UHC, but that their contributions would be 3 times more than they are now, and their deductibles would go back up to the starting point, which is 2 times more than they are now. And nobody in the room wanted to do that. Everybody in the room recognizes that getting a bill and sending it into an entity that's going to work on it on your behalf is of much higher benefit than going back to a traditional model where their costs are going through the roof.
And so I'm just trying to compare this to like the normal thing. Like I once had an actual job where I worked at a school, and so every year we brace ourselves for the renewal, and it was always 15 to 20% hike from it was either Cigna or Aetna or Blue Cross. We kept switching every single year to try to get the least bad increase. Our broker would valiantly negotiate it down to 12 to 15%. This is what you're talking about, where you're cutting it in half.
Yeah, and mostly because of the reference-based pricing, but not just the reference-based pricing. That's the method in which we pay less for healthcare. That's the only way to get around it, is to remove the network. And you have to replace it with something, right? There has to be some kind of payment methodology if you're going to take away the network, aside from cash pricing, I suppose. But what it really does, what reference-based pricing does, is removes the network and all those contracts. So now, in this case, the client I went to today and many others that we manage, now we don't have a network or a carrier to answer to. We don't have to follow their rules or their guidelines. And so now we can get into not only paying for care through a reference price, but we can go directly to providers and pre-negotiate care for elective procedures we know people are going to have. Or we can go to a hospital system and negotiate a direct contract with them for all members of a health plan.
So it's like when you're doing network PPO stuff, it's like, okay, for this year now there's monopolies and we have no leverage, as opposed to we're going to go shop around and we're going to look at quality data and decide who gets good outcomes, and then ask them if they want our business and what are they willing to do to get our business.
Absolutely.
So it's like it gives the end user power that they would never have had before.
Yeah, and it is the main driving factor to lowering healthcare costs, quality aside, which is half of what we do. But if we took out quality, reducing costs to a health plan by 40% in most cases allows employers to pass on those savings to the employees, whether that's reducing contributions or deductibles, like the company I sat with today. But we have another company in New York who did the same thing. They're in their third year, and they reduced contributions and reduced deductibles again for a second year in a row. And it's a wonderful place to be as a consultant who's been doing this for a while, because there's been very few meetings in my career that I've sat in on or presented on where I've actually presented a massive cost decrease in this industry. It's almost unheard of until now.
Mm-hmm. So you guys are a successful agency, but you're not a big agency.
Mm-mm.
Why are you not, like, why isn't everyone coming to you?
Well, sometimes, some days it feels like everyone is coming to me. It depends on the day. I think there's a little bit of stigma associated with the disruption that we're causing, frankly. It's scary, and it's new territory, and people worry about what will happen to their paycheck and their commissions. Now, our CEO is David Contorno. Everyone knows him very, very well. And he just happens to be a little bit brash in nature, and he's fairly unafraid in his approach. And so he's successful. And a lot of people come to us because they've heard him speak, they've heard him go through his, here's what's wrong with the system.
Well, I've heard people at conferences muttering that they don't understand why he doesn't walk around with bodyguards.
He does. He has me.
Yeah.
I'm a weightlifter. I got him. It's okay.
Right. You're only one of Charlie's Angels.
That's all I need. It's all he needs. No, he does. Yes, he's a target sometimes, for sure. But I think those who target him, quite honestly, are other brokers, other consultants. And I think it comes from a place of defense. Because if you are a consultant, an advisor, who has listened in on one of David's talks about commission, for example, you might feel a little bit defensive about the fact that your entire paycheck is based on carrier commissions.
Can you explain that?
Yeah. So if you write some policies with, I don't know, Blue Cross, Cigna, whoever, generally consultants get paid as a percentage of the premium that the employee pays. So if you're selling a group, but the employee-only premium is $500, well, the broker might get 4% of the total premium spend for that group as their compensation for selling that. Well, there's a couple of conflicts there. The first is the seller is now paying you for something that the buyer is purchasing, and you're supposed to be representing the buyer. So there's a bit of a conflict there. Being paid by the seller to represent the buyer
This is like real estate agents.
Except real estate agents, I don't think, are allowed to do that. They're not, in most cases, real estate agents aren't allowed to represent both. And if they do, they have to be very clear about that. And the second conflict is that every time you deliver one of those increases you talked about, 16% increase this year because of whatever trend or whatever they want to justify it with, well, that commission goes up too, right? Because if you're making 4% commission on premium and the premium went up 16%, you're getting a pay raise every single year for delivering a poorer result.
So you might be conflicted if you feel like, I'm going to negotiate really. Let's say a broker ignores that and I want to negotiate really hard on behalf of my client, and they discover that I've just negotiated myself out of $30,000.
Yeah. But, I mean, the good consultants will do that. There are good consultants out there.
Yeah. But you don't want a system in which case, in which the good thing to do is the thing that's disincented.
Right.
And you don't want to have to rely on people being saints in order to represent you properly.
Well, and it becomes difficult for the agent because, and I don't blame agents or consultants for this at all. And I think the reason that David gets a little bit of slack on this is because they recognize that it's really not, it's not the problem of the consultant necessarily, because a lot of consultants are in positions where they can't avoid that. For example, in the larger group markets, you can mess with commission a little bit. You can make it higher, lower. You can charge a PEPM, per employee per month commission, instead of the percentage of premium. But when you get into the smaller group market, the rates are set and the commission within the rate is set already, and there's no moving it around or being flexible. So I think we can give him a little bit of slack in the fact that he's right to call out the fact that the system incentivizes consultants to do a worse job. Now, that doesn't mean a consultant is going to purposely do a worse job, but it does mean that by default, they're going to get paid more if they do. And unfortunately, some consultants that work in the smaller group markets can't get away from it even if they wanted to.
Mm-hmm. Yeah, so it's basically telling people that they're taking advantage of their clients whether they want to or not.
Yeah, whether your intention is to or not, unfortunately, that's the insurance carrier has made it so that they are incentivized, again, whether they think they are, whether they knowingly do so, they are incentivized to have costs increase every single year.
And they can't just create a model like yours.
Well, they can if they're in a larger setting, yes. But when you get into small group, it's already set within the rate, and so you can't do anything about it. But in a large group, yes, you can. And what we do too, we take our compensation directly from the client. So we either come up with a PEPM, that per employee per month cost, based on the client if they're more comfortable with that, or we come up with a flat fee every month. But there is no client that exists in ePowered that takes commission that is not reportable, transparent, or comes directly from the client. And I think that's what's really unique about our agency. Aside from all the disrupting that David does, outside of that, that's pretty unique, I think.
Right. And see, for me, as I think about sort of business incentives, I don't trust myself at all. I don't think I'm a good person. I don't think that I'm any, I think it's dangerous to think of it as like, I wouldn't do that. I would be above that. So I make sure that, like for my podcast, I don't take any advertising.
You don't? Okay, why?
Right? Because I would be a whore. Right? If someone came, like if let's say Vitamix sponsored the show, I wouldn't have Dr. Esselstyn who tells people not to drink smoothies because we need to chew our food.
Right.
Like, well, I couldn't upset Vitamix or whatever it is.
But I've heard Vitamixes are pretty good.
Yeah, but I think they're great. But the point is, I would compromise if I felt like I was dependent on that money.
Absolutely.
And so, I have a coach training program to train health coaches, and I believe in the program. I think it's the best program out there. Mm-hmm. And when people, I do enrollment interviews, that people pay $25 to have this conversation, mm-hmm. which will get rebated if they decide to do it, and they get refunded if they decide not to do it. Mm-hmm. But I sell pretty hard. I say I insist on 100% money back guarantee for the entire program if you're not happy with it, mm-hmm. because otherwise I know I'm going to sell hard, and it would be the wrong thing to do if I got them in and they didn't have recourse. And it's not because I'm a good person, it's because I know I'm not.
It's because you're aware that those things will trip you up, right?
Yeah.
It will make you stop and pause. But the problem in insurance, in this industry, is that some consultants don't have a choice. Some consultants don't know that there's an alternative way. And it's sort of always been this way. And people tend to have that perception, like, well, it's always been this way, so that's just how it's going to be. And what David has created at ePowered is him essentially standing by himself, now with a couple other people, but in the beginning it was just him standing up by himself and saying there is another way, and I'm going to figure out what it is, and I'm going to do it because it's the right thing to do rather than the thing that's always been done.
All right. This reminds me of this movie I saw recently. I don't know if you've seen it. It's called High Flying Bird.
No.
Oh, you got to check it out. I think it's a Netflix original.
Okay.
It's about a sports agent
uh-huh.
who figures out that his players are being screwed essentially by the NBA. He's representing a young black kids right out of college, or out of first year of college, mm-hmm. and NBA, all the owners of these rich fat cat white guys, and he basically wants to change the system to stream live on YouTube to get the players to start their own league, to mm-hmm. This kind of disruption.
Yeah, that's essentially it. Just a far more boring subject matter. That's all.
Well, I hope not after this conversation. Before I let you go, there's a couple other things I wanted to just bring up. One is you have had your own quite amazing health transformation.
Mm-hmm.
If you feel comfortable talking about it a little bit.
Yeah, I do actually. I lost quite a significant amount of weight fairly recently. I lost 140 pounds. So I started out tipping the scales at about 300 pounds back in 2015, and I have been obese most of my life. I started out getting chubby when I was a teenager, and blamed it on development, just developing early, getting chubby, got that baby fat is what my mom used to call it, and then I just got fatter and fatter over time, and eventually I got to 300 pounds. And in May of 2015, this is where actually David Contorno and I disagree. He thinks that wellness plans and health coaching is ineffective in terms of ROI. And I would agree with that from a financial perspective. However, I disagree that they don't have an ROI. I think the ROI is personal for a lot of people, because I engaged with my health coaching program that I had at the time that was provided to me. Now, it wasn't very robust. It was just access to a nutritionist and someone who could help me figure out what the heck I needed to do to even start down a path of losing weight, which seemed very overwhelming at the time. And I essentially spent a considerable amount of time, about a year and a half in total, tracking my calories, eventually tracking macronutrients, going to the gym pretty consistently, and I lost 100 pounds the first year, and then I lost another 40 pounds the second year through a weightlifting program. And it's been, now it's 2019, so I guess I've been maintaining for a couple years now.
Mm-hmm. And so, you talk about like health coaching possibly being ineffective or ROI irrelevant. And I think that's true for a lot of people who don't change.
Absolutely.
Right?
Yes.
Like the problem with ROI is not that, gosh, we're doing this wellness program and people are going from 300 pounds to 160 pounds and they're reversing their, but we're still not seeing a financial, it's like you're not seeing people actually lose weight and get better.
Mm-hmm. Yeah. And I think there's merit to that discussion actually, because I disagree that there's not an ROI. I think it's not it can't be bucketed into your health plan spend, because chances are somebody who is unhealthy is probably not getting the health care they need to get healthier anyway. So the idea that they would be consuming any at a maintenance level is unrealistic.
Right, so then they're not taking their car in at all.
Right, they're
so
not.
Now all of a sudden you give them education
yes.
and tools on car maintenance, and now all of a sudden they're getting oil changes, and you're seeing
yes.
their spend go up.
Yeah, I think that is such a good observation on your part, and I think it's absolutely true. And I think what we need to start seeing is that health spend on the maintenance and preventive stuff go up, so that we can avoid the unhealthy, catastrophic illnesses that come later as a result of not going in for your maintenance, right? Just like the car analogy. And for me, health coaching was key, because when you're starting at 300 pounds and you've been that way for a while, the idea of losing 25 pounds, let alone 140, is pretty far in the distance. And it seems really unlikely that you could achieve that. And so just for me, just having access to somebody who could help me break down the math, because I fully believe, and I've said this over and over again, weight loss is simply a math equation. That's all it is. It's calories in, calories out. No matter how you do it, that's what it is. And at the end, you're going to output what the answer is. But I needed somebody that could help me figure out what the equation was, what needed to go into it in order for me to get that output. And health coaching truly set me off on the right path. So he and I agree on a lot of things, which is why we're business partners, but we disagree on wellness and health coaching. I think it has a significant value in an employer health plan.
Mm-hmm. Well, I hope WellStart gets to prove it.
I hope you guys do too. And you know what? I've just started learning about your immersion programs, and I'm pretty excited about it. I hope you'll talk about that at some point.
Yeah, we talk about it.
Yeah.
I interviewed Olivia last week. We got together.
Nice.
So we talked about kind of because we went to these two conferences in the same month span. One was the World Healthcare Congress that you and I saw each other at, and the other was a plant-based prevention of disease conference. And like we feel like these two worlds need to know each other.
Yes,
because there's such overlap. Like, you know, you're working on getting healthcare to cost less, and we're working on getting people to require less healthcare.
Right.
But you're also doing that.
Yep.
So there's a lot of overlap, and the way we're working also gets people to spend money more efficiently on better things.
Yep. There's a lot of aligned intentions, I think, because, and you're right about that. We do have overlap in that we focus on getting employees to a higher quality of care. But if we could capture employees before that interaction needs to happen, then they won't need the care at all. And that's our hope, right, is that they're just going in for their preventive maintenance and staying well.
Right. And the other thing we're working on is, our Chief Medical Officer, Dr. Sarai Stancic, just released a documentary called Code Blue, Redefining the Practice of Medicine. It's largely based on her experience becoming an MS patient, being on this debilitating cocktail of drugs for a bunch of years, never being told that she could address it through lifestyle, and the fact that so many physicians don't believe that radical change is possible. There's a lot of people who would say to you at 300 pounds that, look, you can't do it. Like, look at the Biggest Loser people. Like, they gained it all back. It's not maintainable.
Yeah.
And I find it fascinating that, you described yourself earlier as like a numbers geek, and how, like, the psychological rift between how good we are at our jobs and how bad we are at our health.
Yeah.
When like our coaching model is essentially a business model, and people have all these strengths around, I get evaluated on results, I set plans, I create, objectives and key results, I have key performance indicators, like I can kick ass at work, but like, oh my God, weight loss, it's such a mystery. When I think you're 99% right about calories in, calories out.
Yeah.
I would say the 1% I would add is calories burned through the process of eating.
Right.
So there's like foods have different, your body responds differently and produces more thermogenesis to certain foods than others.
Yeah.
But essentially, yeah, I mean, and leaving like health aside, like there's lots of unhealthy ways to get thin too.
There are, yes.
Right. But if you look at, if you just take your skill at numbers and you needed a health coach to kind of help you tap into your own natural abilities, and some people are not numbers people, but they also have natural abilities that aren't being tapped. And like, to me, that's what I see as the secret sauce of health coaching, is getting people to basically look at the bright spots in their behavior and in their capabilities and applying it to this world of essentially shrouded in shame.
I think you're right about that. And I want to go back to an earlier comment you made, which is sort of the placebo comment, but it has value here, because I think that regardless of my ability with numbers and data, knowing that it's a math equation, I think a lot of my struggle in reaching out for help while it's trying to figure out the equation is also just feeling powerful enough that I can actually tackle it. And I think we're going to talk about the empowered leadership thing too, and it kind of segues in, but it is about finding your power. And a lot of people talk about having willpower or having the motivation, not realizing that those two things are not going to exist very often for you, and you sort of have to create them, right? People ask me, the most common question I get is, how did you lose weight? I did it. I did the thing, and I prioritized myself.
Amen.
I just did it, and there's no secret to that. I'm not going to rattle off a diet pill name to you. I'm not going to tell you like I did a certain diet, because I didn't. And I think once people have that feeling of strength within them, whether it's fake in the beginning or not, they need that little bit of power behind them to just do it.
See, I was talking about this actually on the podcast about a month ago with Josh Lajani, our other my business partner with whom I joined WellStart a little over a year ago. He was 420 pounds. So, I gave you a copy of Sick to Fit.
Yes,
right?
I got it.
He's the guy, and he was talking about how like he unabashedly embraces power. Like he likes to lift weights because he feels powerful.
Absolutely.
And so many of us shy away from like, I don't want to be powerful. Like powerful, like that feels irresponsible. And just like and I love what you said, like the difference between willpower and power.
Yep.
That
you don't have to will yourself to have it, is the thing. You can embrace it and use it at any point you choose to. It's just having the ability to choose to do it. And so many people are waiting for that big reveal. Like one day I'm going to wake up and I'm going to have the willpower. And I really want people to understand that that's unnecessary. You have it already. You just have to not be afraid to use it.
So let's segue into empowered leadership and women in leadership. I think power is less culturally acceptable for women to wield than men. We're seeing, we saw it in Game of Thrones.
I'm the only person on earth that doesn't watch Game of Thrones. I think.
I don't watch it either, but I can't. I read newspapers, and so I'm reading stories like it's real. And I saw a conversation with like Elizabeth Warren and Alexandria Ocasio-Cortez complaining about how the women didn't get to be top leaders.
Yep.
But it's certainly part of our zeitgeist.
Yes.
So talk about what's your work around that?
Well, it started as a point of frustration, if I'm honest. And it's not necessarily just for women. It started out that way. And I'll tell you how this came about. I've been feeling frustrated because I go to a lot of conferences, whether I'm speaking or, E-Powered is being represented or I'm just attending. And I notice more and more that people are putting together these tracks that are designed just for women. And this happened at the conference that you and I saw each other at a few weeks ago. And when I start digging in and looking at why are there tracks just for women and what are they talking about? And I'll probably gain a little bit of criticism here from women when I say this, but a lot of these tracks seem to be focused on us highlighting the segregation between women and men in our industry. And I don't know how that is helpful. I've been a fat woman. I've been an entry-level administrative assistant. I've been all these things that would have set me back in one way or the other. But the only way to bridge that gap, that exclusion that we feel, women versus men, is to simply just sit down at the same table as a man and be able to hold your own there. And I don't have a problem doing it. In fact, I feel like I have, as a woman, as a 35-year-old executive woman, I feel like I have all of the substance and the experience and the contribution at a table full of men, women, young, old, whatever. But I feel like women often feel like they're in this weaker position, like they can't speak up or they can't take a spot at the table. And I created Empowered Leadership at first for women to just try to bridge that gap, not just to bridge the gap by complaining that there is a gap, but to bridge it by engaging with men on their exact same level and not being fearful of it, not feeling like you don't have a place there. But then I realized that this doesn't apply to just women. This applies to people who are young. So a lot of times I hear that I'm too young to be a chief operating officer. I'm 35. Sometimes it's that I'm a woman. Sometimes it's that I'm from the West Coast and therefore I must be this liberal hippie of a person, right? People are just predisposed to making assumptions about people based on some of their demographics. And I realize it extends far beyond women. It extends to minority groups of color, young, old. And so I created Empowered Leadership because I wanted to create a community that stops talking about the gap and just starts bridging the gap instead and putting themselves in positions that are maybe uncomfortable for the first 5 or 10 minutes. But at some point in that first interaction, you find your power. And you realize that we're all doing the same thing, and we all, one way or another, have the same amount of knowledge and the same ability to contribute, regardless of male, female, 35, 65. So I don't know quite where it's going yet. I hope that we will have a nonprofit that is educational, that motivates people, that inspires. It's going to be a sharing community. I really do sound like a liberal hippie now when I'm talking about it, but that's the idea.
I don't have a problem with that.
I don't either. I wanted to create an environment where...
Yeah, you're interested in other people succeeding.
Yeah, and I really am.
That's so countercultural of you. We should be putting other people down, stomping on their necks.
I'll let you in on a secret, Howard. As a woman who was 300 pounds for a long time, I'll say a few things that might make me sound a little pretentious, but I promise it'll humble itself out at the end. I have always been intelligent. I've always been really driven. I've always been a good speaker. I've always been really good at my job. I've always had these qualities that I have now that are now far more appreciated and focused on, and people are more quick to point them out now that I'm not 300 pounds. And it is not coincidence to me that my career has taken off in the same amount of time that I have been a thinner woman, and perhaps arguably a more attractive woman, right? And I was talking to a girlfriend of mine about this the other day, and I told her I don't think it's coincidence that those two things have happened simultaneously. And I was inclined initially to blame other people for that, for looking me over because maybe I didn't fit a mold that they wanted me to fit, or I didn't look a certain way, or my image didn't work, regardless of my intelligence. And while I was talking to her, I realized that that might be partially true, but the real truth is that I took less risk and I took less chance because I felt like I wouldn't fit into whatever mold I had assumed someone had set for me beforehand. So if my career has taken off in the same period of time as I have been a thinner, more attractive person, it is largely because I've chosen to view myself differently in this body, in this image, and I'm no longer afraid of what other people will perceive me to be. And I think I want to get that message across to other people, that if you're doing that to yourself, know that you have to place some of that accountability back on yourself too, and the only person that can adjust that is going to be you.
This is so deep and complicated, and there's so many responses I have, and about 40% of them will get me into trouble if I don't think really carefully about them. But I mean,
you could edit anything out.
Oh, I don't edit myself. I just let my listeners tell me off. But no, I mean, one thing I'm thinking about is I was reading up on different charities because Josh and I have this. We're starting some swag from Sick to Fit, and we didn't want to make money at it. We just wanted to make it real simple and just donate. So I was looking at Girls on the Run, which is this organization, and I was looking at some of the other sort of organizations for empowering girls. And one of the things that struck me that I'd never thought about before was that all this talk about, like, when people come and tell young girls, you can do anything a boy can do, it's actually a disempowering statement.
Is.
And it's like, holy shit, how did I not see that?
Right. It is. You're so right. Because they can do anything they want to do. It doesn't have to be compared to somebody else. And you know what else? People get caught up in this in weight loss too, or in bodybuilding. So I got into weightlifting pretty heavily when I was losing weight at the end of it. And I constantly found myself comparing me to, some woman on Instagram that had obviously been bodybuilding a lot longer than me. And I think we teach our young girls that that's okay, that behavior is okay, that you can be an image of somebody else that you really can't be, because then you just wouldn't be yourself. Right?
But also that, like, you can do anything a boy can do. You keep hearing it, and it's actually telling you, like, well, we don't think you can, so we have to keep repeating it. Like, you don't keep telling somebody something that's true. Like, you could drive a car. Like, I do drive a car every day. Yeah, but you could drive.
But you know what else? You never hear that statement in reverse, right? You never hear, we don't say to our boys, you could do anything a girl could do, because there's certainly a few things that women do that elude men frequently.
Well, so I want to pick up on that, because, and here's where I do get into trouble, is... So I totally get that part of the agenda of feminism is to break down all the barriers and to create equal opportunity. And as a liberal hippie, I look at our society that has been male dominated for thousands of years, and I'm like, is that the best we can hope for, that women come in and fuck it up just as bad as men have? Or can we ask of women to bring something better to the table. Like, I don't know, like in terms of like being a benefits consultant, like is there a woman's outlook, a feminist approach that can not just like I'm the same as all the men at the table, but I bring something else that's valuable that's been missing?
I think you hit the nail on the head, and this is exactly why, and David will tell you this too, but the reason that David and I decided to do this together for E-powered benefits was because he says it best, that I am the yin to his yang, right? Whereas he will stand up in front of a room full of people and just straight to the point, straight to the truth. And it can sometimes come across as a little bit cold because it's very factual in nature. Whereas I tend to look more at the reactions of people and how their body language is instructing me on what would be best or what would feel best for them, because I recognize that people only do things, or people are only incentivized to do things mostly when they feel a certain way about it, right? And so when we talk to employees, we want to get them a little bit pissed off about the state of the current system, because we know if they get a little pissed off about it, they're more likely to want to do something about it. And so I think I provide something that's a little bit more comforting, and I think women do in general, but often that is mistaken for just that we just come in and we like give warm hugs and we, give a little smile and everyone feels better. But I have a lot more to contribute than that. So I think I would, if I was just being broad, what I really want to get out of empowered leadership is allowing women to feel like they do have something to contribute that can't be found necessarily in men, just like they have something to contribute that we could never emulate either. But that doesn't mean that what they have to contribute is less valuable than what men do. It just means that it's different, but it still has a place, and it should have a place, and hopefully it will in the future.
All right. And that involves not just mentoring and role modeling for women, but advocating for men to recognize the value.
I could not mentor a woman to save my life. I have to tell you, a lot of people think that I have my shit together. I don't. I am the quirkiest, most awkward. I'm clumsy. When I walked in here to do this podcast with you, I spilled my coffee on my foot, and my sandal has been wet ever since.
Oh, I didn't notice it. A typical male response. I did not notice your pain.
But I am far, far from perfect. But I think that's when we're most teachable, right? And that's when we're most apt to teach, is when we recognize that I don't have it all figured out, but maybe if I tell you what I know and you tell me what you know, when this all gets mashed together, we can have some really good buttery mashed potatoes and come out of this with a little bit from you, a little bit from me, and we'll both be a little bit better when we exit. And that's really what I'm trying to do. And I don't think it's me mentoring people, because I frankly don't think I'm qualified, but it's a community that's willing to all chip in a little bit.
Mm-hmm. Well, it reminds me, my friend Peter Bregman has a leadership academy, and the leadership skills that he teaches are very much about empathy and about emotional courage.
Yep.
And emotion is a feminine word in this culture. Right?
Yes.
Men aren't supposed to show it.
Right.
But we've seen, I've been to his workshops and I've read his books, and very much you see the really powerful male leaders are the ones who are in touch with the qualities that our culture bifurcates as feminine.
Yes, you're so right about that.
The other thing I was thinking is, I don't know if you know the work of Claude Steele, who's I think he's at Columbia University, a psychologist. He wrote a book called Whistling Vivaldi, and he's a black guy. He went to University of Chicago, and in his 20s, and he noticed that people would cross the street. They were scared. He was like this, strapping black guy. And he'd sometimes, he'd wear sweats and things that they would associate with a dangerous person. And he noticed if he would walk down the street, if he would whistle the Four Seasons, then all of a sudden, oh, you're one of us. And he did a lot of work on, I think, threat stereotyping, which is if you are aware of a negative stereotype about your group, that will actually interfere with your performance.
Yes.
And
I fully agree with that.
So there was all these studies women taking, or girls taking math tests doing worse than boys until they're told, a total lie, that this test has been calibrated so that women do as well as men. And it was the same test.
Right.
And of course, and they did just as well. Or
Yep.
or black kids at Princeton being given a test, either told that it's a test of athletic ability or a test of strategy. And it's the same thing.
Right.
And they do better when it's a test of athletic ability than
Yep.
strategy. And that part of the work of empowered leadership is to get women or whoever to recognize their own sort of wheels spinning around the stereotype threat,
Yep.
so they can show up as their full selves.
Yeah, and it really takes a community, I think. I've started interviewing women mostly. I have a couple men in the fold too. But one of the rollouts of this organization is going to be to highlight the thing that you've struggled with the most and how you overcame it. And I've been collecting these stories from women, and one of the common themes in all of them is that they had something or someone that provided them some level of support or encouragement to move on, to be better. And I can't tell you how much importance that has, especially as a woman, maybe. You know, I have a couple of girlfriends. We refer to ourselves as the tribe. You know, there's just a few of us in there, and we all, the kind of people that you can call up whenever you want, and they're going to be honest with you and tell you the truth. And if you're being crazy, if you're having an emotional breakdown, and I have a couple guys in my circle like that too. But I think the idea that you have a community of people that you can lean on, so you don't have to feel inadequate because you don't know something or you don't know how to approach something. There's a woman she's in Los Angeles. Her name is Dawn McFarland, and she works with the National Association of Health Underwriters, and she is somebody who completely reinvented herself and her profession after she had a really bad experience at her current employer. And she went through an experience that really set her back and made her feel inadequate as a woman in her job. And it affected her to the degree where she ended up losing her job, and she had to reinvent herself. And for whatever crazy reason, she chose insurance a few years ago. And I laugh with her and I tell her, I don't know why you chose insurance, but I'm glad you did, because now, even though she's fairly new at this, she had a community at the time behind her that encouraged her to say, we know you don't know how to do this. We know that you're not probably going to be good at it for the first 6 months to a year, but we're here to give you as much help as possible. And some of those associations, NAHU being one of them, is really notorious for providing not just networking, but that comfortability around someone to just be helpful. And again, I'm going to sound a little bit liberal in nature, but it's really about just feeling like someone's got your back, even if it's small, if it's big, if it's weight loss, if it's work related, if it's leadership related, if it's just the fact that you're feeling inadequate as a woman in a room full of men in the insurance industry. Just having that feeling like someone's got my back and I'm going to be able to fall over a little bit and get caught. And I hope that spreads a little bit wider. And it sounds like a foo-foo idea, right? But it's how most of us get by in life. When you think about what happens when you encounter something that is of personal tragedy to you as a man, I'm sure you go to somebody. There's somebody in your life that provides you that unwavering support, right?
Well, I mean, the idea that we human beings can do without it, you know, is insane, but it's a part of this culture that we're atomized.
I know.
And that's, you know, like men, I know a lot of men who don't have friends.
I do too, actually. It's crazy.
Right.
I don't know what I would do without my friends.
Like, you know, to me, that's as insane as expecting to be healthy eating only junk food,
right?
Or breathing toxic fumes or drinking polluted water. It's not how human beings are designed to be.
I agree.
And so we have to, you know, the default, just as, you know, your default was to eat the crap that was all around you until you made a decision to do something else. Our default is to be on our phones, go home and binge watch things and not have community. We have to work hard to create the kind of community that's sort of the birthright of every human being in a traditional healthy society.
Well, and I think we can circle this back to how we started this entire podcast, which was on insurance, right? Healthcare, health plans, reference-based pricing. If you think about what we're really trying to do is change the entire healthcare system. And there's no way that a David Contorno or an Emma Passé can do that single-handedly, no matter how brash he is or how comforting I might be. It takes a community, and that's what Health Rosetta is doing. That's what the Health Wealth Certification does with Josh Luke. It creates a community that provides strength in numbers and encouragement and support so that we can have a bigger, more lasting impact. So as with leadership, as with a feminine approach to professionalism, changing healthcare also requires that same group, that same coming together in order to really affect any change at all.
Right, and to take it to kind of a historical perspective, you know, I mean, insurance and healthcare are two of the least liked industries.
Yes.
And yet, if you think of that, like, what's the root of insurance? It was to make sure that everyone was taken care of. Mm-hmm. It was like, okay, so we're going to spread out the risk so nobody is left behind. Nobody is isolated. Like, that's such a beautiful impulse.
Except it fortunately hasn't turned out that way, because we ended up morphing from that ideal to putting barriers in place where benefits were intended to be, right? We went from let's pull together to provide a protective layer for people who are in their most vulnerable state when they're sick or when they're injured. But then the cost of that became so unmanageable that we started putting barriers like deductibles in place. Like, okay, well, we'll give you a benefit, but only if you're willing to put up this much first. So as with most things that start out well-intended, it becomes a little murky along the way.
Yeah, I mean, that's, it's true of medicine too. Like,
yes.
Right, first do no harm. Medicine is all about doing harm.
Yeah, I agree.
I mean, look at, like religions all started out beautifully, and most of them are busy cutting each other's heads off. I think there's but I think there's value in going back to first principles. Mm-hmm. And for me, when I think about the potential of insurance as something that holds all of us as community, mm-hmm. It sounds like that's kind of what you are pushing towards.
I am,
and it's it's much more than just all these acronyms and initials and spreadsheets. It
is. I truly believe that as a collective we can do so much more, and there's a lot of people in the industry that criticize David more than me, for sure. But those people even have a place to contribute to. Like those people who've been doing it the old-fashioned way or the traditional way, or who have been incentivized in the old system, also have a contribution to make to the solution.
Yeah, there's a quote. I'm going to get it a little bit wrong. I just actually texted it to Josh 2 days ago. I might pause for a second, see if I can bring this up, because it was so powerful and beautiful.
I love it.
It was by Martin Luther King. Here it is. You have no moral authority with those who can feel your underlying contempt.
That is pretty powerful.
So isn't that great?
Yeah.
So,
you'll have to text that to me. I could use that.
I will do that. Yeah, I need that as a tattoo before I go out and piss people off. This has been such a beautiful, amazing conversation. This is why I wanted to do. It's great to do it in person.
Yes, thank you for driving all this way. I told you when we started. I just assumed that if you're in North Carolina and I'm in North Carolina, we'll be close by. But apparently that's not how that works.
No, I grew up in New Jersey, where it would have been more true. But no, it's a beautiful ride, and it's great to just experience your energy and passion in person. How can people reach you, either both for the benefits and for the empowered leadership?
Probably both best on LinkedIn. So I'm fairly active on LinkedIn, and then the Empowered Leadership LinkedIn page is up. I expect it to be built out a little bit more, but all my contact information is there. Okay, you better spell your last name for us. Passé, P-A-S-S-E. It's French. It's a French word, but it's a German family name, which is sort of weird, but that's for another podcast. Okay. So Emma Passé on LinkedIn, and then people can follow up and
find out all about what you do professionally and what you do as a give back to the community through our leadership.
Wonderful. Thank you so much. Cool. This has been really fun.
Oh, for me too. Thank you so much.
Of course.
All right, dear listener, you hung on till the end. Good for you. Good for everyone. This is, I think, really important stuff. So if you enjoyed this episode of the Plant Yourself podcast and you'd like to support our mission, the easiest way to do it is simply leave a review on Apple Podcasts. And if you'd like to find out more about WellStart Health and one of our upcoming cohorts, our 12-week program to get you fit and healthy, check out wellstarthealth.com/program. And check out the show notes for today's episode. I've got links to Emma's stuff, to a couple of the books we talked about, and that's at plantyourself.com/327. Wow, 327 episodes. That means there's over 300 archived episodes at plantyourself.com. If you're new to the show, you can go back and dip your toe into any of those. And make sure that you're subscribed to the podcast. I've got some great interviews coming up in the next few weeks that are in the can, and I'm really excited about sharing them with you. So in garden news this week, the garden is hopping. We are getting more squash than we could possibly eat. I'm looking for ways to, when I used to use oil, I would make these like zucchini muffins that were basically oil and sugar with a cup of zucchini in them. It wasn't that efficient in using the zucchini, but it sure got a lot of oil and sugar into my system, which made me happy in the moment and miserable later on. But now I'm looking for ways to process massive amounts of zucchini in a whole food plant-based way. Made a zucchini lasagna with no noodles, just sliced zucchini, and I'm going to be working on zucchini curls and sauteed zucchini in water and broth. And you got any ideas, just drop them in the comments and you can help me out. Also, we're now getting about a half a cup of blueberries a day. The raspberries and blackberries were a disappointment this year. The grapes look like, barring some unforeseen thing, like we might get a lot of grapes. It'll be the first time in several years. And we've also put fences around the sweet potatoes. Something was chewing up all the leaves, so those are protected now. And we've got almost a 7.5-foot fence almost all the way around the garden. So we're really looking forward to being able to share more of our bounty with humans and a little less with groundhogs, rabbits, and deer. In running news, my foot is feeling better. I did go and play a hard practice of Frisbee on Saturday, and it felt terrible all over again. So I am going to absolutely give it 2 weeks of no running, just walking. Did 3 miles today, did 4.5 miles yesterday, just walking in the morning, no running, no pounding. And luckily this weekend, I'm off to Florida for the American College of Lifestyle Medicine Roundtable, so I will not have to choose between Frisbee practice and protecting my foot. So I'm going to keep walking. I will be on the beach there in Naples, so I'll be walking on sand, and hopefully that will continue my rehab process. Okay, thanks. Thanks to Will Ridenauer for allowing me to use Sabali Dawn, the Dance of Peace, as the theme music for this show. And you can check out willridenauer.com for more of his gorgeous West African kora music. And, of course, thanks to all you Plant Yourself podcast... All right, that wasn't a great start. Thanks to all you Plant Yourself podcast patrons. Thank you also to the pop filter in front of my microphone that keeps me from popping too many P's when I say Plant Yourself podcast patrons. Here we go. Kim Harrison, Lynn McClellan, Anthony Disson, Brittany Porter, Dominic Mara, Barbara Whitney, Tammy Black, Amy Good, Amanda Hadley, Mary Jane Wheeler, Ellen Kennedy, Melissa Cobb, Rachel Behrens, Christine Nielsen, Tina Scharf, Tina Ahern, Jen Volkanovsky, David Bizek, The Mysterious, Michelle X, Elspeth Felden, Victoria Dolomanova, Leah Stoller, Alan Christensen, Colleen Peck, Michelle Andrew, Josina, Julianne Roland, Stu Dolnick, Sarah Durkis, Rhymes with Circus, Kelly Cameron, Ray Pedersen, Leanne Peterson, Janet Selby, Claire Adams, Tom Franzek, Jeanette Benham, Gila Stert, David Donahue, Blair Cyber, Dorona Vizov, Gio and Carolyn Argentati, Jody Friesen, Ruth Ann Thunderbrook, Misha Rosen, Michael Warbeck, the equally mysterious Tracy Z, Alicia Lemus, Rebecca Hughes, Val Linneman, Rhymes with Cinnamon, Nick Harper, Stephanie Holmuth, Martha Bargner, Nicole Ramsey, Susan Ahmad, Molly Levine, The Inscrutable Harry R., Susan Laverty, The Panda Vegan, Craig Kovac, Adam Sharp, Karen Burry, Heather Morgan, Ashley Corcoran, Kelly Machia, Dean Norton, Bonnie Lynch, To Plant Happy Oregon, Sabina Kurtzels, Nigel Davies, Mary Blum, Teresa Coble, Shell Rutledge, Julian Watkin, Breed O'Connell, Brian Sheridan, Shannon Hirschman, Kate Rosalind, Ayat, Julie Langholm, Hedegaard, Easy Susan Wakani, Hainline, Aaron Greer, Alicia Davis, Avila L., Heather O'Connor, Carolyn Jensen, Sherry Olakowski of Plant Powered for Health, Karen Smith, Scott Morani, Karen and Joe Crabtree, Tanya Lewis, Kirby Burton, Teresa Carell, Kevin McCauley, Elizabeth Rothschild, Kelly Baker, Miracle Ann, Jesse, Cheryl Dwyer, Jenny Hazelton, Valerie Peltier, Peter W. Evans, Colleen Harrison, Justine Divitt, Joshua Sommermeyer, Dennis Bird, Darby Kelly, Lori Fanny, Linnea Lundquist, Valerie Hummel, Deb Casilla, Emily Iaconelli, Levy Wallach, Rosamund McAtee, Dan McCorney, Stephen Leland, Patty D. Martino, Mike and Donna Kartz, Deanne Bishop, Hildry Elf, Gunter Schmidt, Marjorie Lewis, Kelly Moulton, Trish Adams, Ian Kramer, Nancy Sheldon, Lindsay Bayshore, Gunmerit Hagen, Tracy Gullidge, Laura Heaton, Meg for Mama Says, Rochelle Kennedy, Joan Borstein, and Diana Goldman for your generous support of the podcast. That's it for this week. As always, be well, my friends. So if you appreciate the Plant Yourself podcast and would like to help support the mission of the show, there's a few easy ways to do it. One is to just go to wherever you get your podcasts and leave a review. Let other people know about it. Give us some stars. Give us some love. And that really helps us be found by more people. Something else, of course, you can do is let someone know about this podcast. Someone who you think would benefit. Send them maybe a couple of episodes that you think would pique their interest, or just ask them to subscribe in general. And third, you can join arms and become a patron, a financial supporter of this show. You may have noticed that there's no advertising in the show, and it's free for everyone, and it's supported, paid for by those who can afford it. So if you would like to make a one-time contribution or an ongoing monthly pledge, you can do so at plantyourself.com/gift. All right, time for thanks. Thanks to Will Ridenauer for allowing me to use his beautiful song Sabali Dawn, The Dance of Peace. You can find more of Will's music at his website, willridenauer.com. And of course, thanks to all of you Plant Yourself podcast patrons. Kim Harrison, Lynn McClellan, Anthony Disson, Brittany Porter, Dominic Maurer, Barbara Whitney, Tammy Black, Amy Good, Amanda Hatherley, Mary Jean Wheeler, Ellen Kennelly, Melissa Cobb, Rachel Behrens, Christine Nielsen, Tina Sharp, Tina Ahern, Jen Filikanovsky, David Vizek, The Mysterious, Michelle X, Elspeth Feldman, Leah Stoller, Alan Christensen, Colleen Peck, Michelle Andrews, Josina, Sarah Durkis, Rhymes with Circus, Kelly Cameron, Wayne Pedersen, Janet Selby, Kara Adams, Tom Franzek, Jeanette Benham, Gil Assert, David Donahue, Blair Cyber, Torona Vizo, Gio and Carol Argentati, Jody Friesner, Ruth Ann Thunderbrook, Misha Rosen, Michael Warbeck, the equally mysterious Tracy Z, Aviva L, Alicia Lemus, Rebecca Hughes, Val Linneman, Rhymes with Cinnamon, Nick Harperson, Martha Bergner, Susan Ahmad, Molly Levine, the inscrutable Harry R, Susan Laverty, the Panda Vegan, Craig Kovic, Adam Scharf, Karen Burry, Heather Morgan, Kelly Machia, Deanne Norton, Bonnie Lynch, Plant Happy Oregon, Sabina Kurtzels, Nigel Davies, Marion Blum, Teresa Copel, Julian Watkins, Breed O'Connell, Shannon Hirschman, Linda Ayat, Colm Hedegaard, Isa Tuzawa, Connie Hainline, Aaron Greer, Alicia Davis, Heather O'Connor, Carolyn Jensen, Sherry Olakowski of Plant Powered for Health, Karen Smith, Scott Morani, Karen and Joe Crabtree, Tanya Lewis, Kirby Burton, Teresa Carell, Kevin McCauley, Elizabeth Rothschild, and Jesse, Cheryl Dwyer, Jenny Hazelton, Valerie Peltier, Peter W. Evans, Colleen Harrison, Justine Divitt, Joshua Sommermeyer, Dennis Bird, Darby Kelly, Lori Fanny, Linnea Lundquist, Valerie Hummel, Emily Iaconelli, Levy Wallach, Rosamund McAtee, Dan McCorney, Stephen Leland, Patty D. Martino, Mike and Donna Kartz, Deanne Bishop, Bill Brielf, Gunter Schmidt, Marjorie Lewis, Kelly Molden, Tricia Adams, Ian Kramer, Nancy Sheldon, Lindsay Bayshore, Gunmarie Hagen, Tracy Gullidge, Laura Heaton, Meg for Mama Says, Rochelle Kennedy, Diana Goldman, Stacey Stokes, Ben Savage, Michael Kay, Holly Butler, Diana, David Hughes, Connie Rogers, Claire England, Sally Robertson, Param Ganchi, Amy Daly, Brian Tourville, Mark Jeffrey Johnson, Josie Dempsey, Karen Schmidt, Pamela Hayden, Emily Perryman, Olga Sidorowska, Allison Corbett, Richard Stone, Lauren Vaught of Edible Musings, Aaron Hasty, Sean Owen, Sagar Nayak, Erica Piedra, and Danielle Roberts for your generous support of the podcast. That's it for today. As always, be well, my friends.